Hello guys, hope you are all doing well. Your message decoded RN, I am back again. I want us to be looking at opioid safety and monitoring post-op. Let's look at this scenario. You just got a report on a fresh post-op patient. They had bowel resection. They are on PCA pump. And their pain is 7 out of 10. So you go in and check on them and they push their button. 30 minutes later, their respiratory rate is 8. Their oxygen is dropping and they won't wake up. This is opioid-induced respiration. And on message floor, it happens more than you can think of. Today, I'm breaking down everything you need to know about post-op opioid safety, what to do, when to call, and what to do when things go wrong. Now, why does this even matter on a medical surgical floor? Here is the reality. Post-op patients are not ICU patients. They are on the floor with a 5-to-1 ratio or 6-to-1 ratio. They are getting opioids through PCA, oral meds. Okay, now, how can we monitor patients on opioids? Let's go with the monitoring framework here. I want you to remember this word, RACE, race. Because come to think of it, when opioid toxicity is happening, you are literally in a race. You literally need to run. Okay? So RACA. Now, R is respiratory rate and quality. Okay? This is going to be your number one indicator. Normal respiration is 12 to 20. Below 10, call. Below 8, that is an emergency. But don't just count the rate. Look at the quality. Are they taking shallow little breaths? Are they snoring in a way that they weren't before? That stridor, that deep gurgling snore can mean their airway is relaxing, and that is a red flag. A, arousability. Opioid sedates the central nervous system. That you need to know. But you should be able to wake your post-op patients up. They might be groggy. That is normal. But if you call their name and they don't respond, if you do sternal rub on them and they don't react, that is not normal. That is not normal sedation at all. So you need to use your sedation skill. And most hospitals use the Passero opioid-induced sedation skill, that's the pulse. So S is for sleeping, easy to rouse, that is acceptable. A score of 1, that means they are awake, alert, that is acceptable. If they are slightly drowsy, easy to rouse though, that is 2, that is acceptable. Is this frequency drowsiness? They are arousable, but they do drift off. That is unacceptable. You need to intervene. That is number 3. And number 4, if there's minimal response, okay, if there's somnolence, that is emergency, okay? So C is color and O2 SATs. Cyanosis and a dropping SAT are late signs. So don't wait for SATs to drop to act. If your patient is pale, mottled, or bluish around the lips, they are already in trouble. Your SAT monitoring is your friend, but it lags behind reality by minutes. So you need to treat the patient, not the number. E, equipment and the environment. What do I mean by that? Is the PCA programmed correctly? Is the dose and lockout interval that was ordered correctly programmed in the system? Is anyone else pushing the button? Maybe it happens. Yes, this happens. Family members do press it for the patients, thinking they are helping the patient. But remember, it is called PCA for a reason, patient control analgesia. So it is only the patient that has absolute control of the PCA. Even you, the nurse, you don't have control. It is only the patient that has absolute control of the PCA. Now, which kind of post-op patients are at risk for respiratory induced post-ops? Opioids, sorry. Not all post-op patients carry the same opioid risk. These are some of the people you need to watch out for. Patient with sleep apnea or obesity with hypoventilation. Okay, already their baseline respiratory drive is already compromised. So even small opioid doses can put them over the edge. So they should ideally be on pulse oximeters continuous. And you have your opioid naive patients. That is like no tolerance or whatsoever. Especially the elderly patient who has never had narcotics in their life. They can drop their respiratory rate on standard dose that wouldn't even blink an eye on somebody who is on chronic opioids. Then you have your elderly patients. Do you know why? I think you know why. Yes, you guessed right. Slower metabolism, decreased renal and hepatic clearance. So in that matter, the drug stays in their system for so long before being excreted. And patients on multiple sedation medications. So patients on opioids, benzos, antihistamines like Benadryl. These are dangerous cocktails. So you need to always check your ma before you give anything. And also patients who just received bolus from the PCA or a dose change. Because peak effect is when they are mostly vulnerable. So you need to reassess your patient every 15 to 30 minutes after any IV opioid. Okay? Now, when to call a doctor and what to do. Listen, call the doctor whenever respiration is less than 10. Your sedation scale or your pulse is scoring 3 or 4. O2 sats are trending down despite all the necessary nursing measures you've done, like repositioning, stimulation. Patient is unrousable. Any combination of the above, you need to be calling the doctor. Now, and this is where teamwork comes in. This is where delegation comes in. You can't be doing this alone. You need to be delegating things to people. Can you get me this? Can you get me that? Can you do this? Can you do that, please? Don't do this alone. So what to do while you are calling the doctor? Stimulate the patient first, call their name, do sternal rub, get them to take deep breath. Reposition them, head of the bed up. Oxygen, give oxygen as a supplemental O2, right? Stop any opioids right away. Pause the PCA and hold any scheduled doses. Then quickly get somebody to grab Narcan. You need to know your Narcan numbers. Okay? So you dilute, Narcan comes in 0.4 milligram per ml. So you dilute the 0.4 milligram in 10 mils of NS or normal saline. And then you can give 0, that gives you a concentration of 0.04 milligram per ml. So you can give 1 to 2 mils every 2 to 3 minutes and titrate their respiratory rate. Not the pain level. Your goal is to reverse their respiration. Okay? So, one thing you need to remember, Narcan wears off within 30 to 90 minutes. But opioids can not last. So you need to watch them very closely. So everything goes well. Now, after all this, we need to talk about documentation and communication. Okay? You need to document your sedation skill every time you assess your patient's pain. Because the pain assessment moves with the sedation. They go together every single time. If you only chart the pain or the pain score, you are missing half of the picture or half of your assessment. So always remember you chart your pain plus your sedation skill. And when you call your provider, you need to use the SBAR, situation, background, assessment, and recommendation. So you can say, oh, situation, I have a post-op patient, day 1 bowel resection on PCA hydromorphone. Background, she's been rating pain 6 to 7, received several PCA doses over the last hour. Assessment, respiratory rate is now 9. She is on a pulse score of 3, O2 SATs 91% on room air. What do you recommend? I'm requesting you come and evaluate this patient or consider holding or opioids and ordering a PRN. That is tight, clear SBAR that nobody can ignore. Okay? So, in conclusion, post-op opioid monitoring isn't just a nursing task. It's the difference between a patient going home and a patient not going home. So know your RACE framework, your RACE framework. Okay? Know your high-risk patients. And lastly, remember your NACAN dose. Keep it in mind. Know where your NACANs are kept. Because in case of emergencies, that is when we don't even find anything. So familiarize yourself with where NACANs are kept so that you don't get yourself looking at different places in case of emergencies. If this helped you, save it for clinicals. Pass it on to your classmates. Drop a comment below. And hopefully this helped. Okay? Don't forget to like, subscribe, and I will see you in my next video. Thank you.